Welcome everyone. My name is Jay Cranston and I am a marketing manager at Signifier Medical Technologies. And I want to just start off by thanking you all for joining us tonight for this exciting discussion with Dr. Zelk. We're really happy to have you. And
thank you.
Before we get started, I just want to make sure that everyone should feel free to ask questions in the Q&A box at the bottom of the screen. So feel free to ask your questions throughout the webinar if something comes up, and we'll answer some throughout the webinar, but we'll also leave 10 to 15 minutes at the end for a Q&A segment. So don't be shy, feel free to ask those questions. So thank you, Dr. Zelk, for joining us, for giving this great discussion on eXciteOSA. Just a little bit about Dr. Zelk. He is a double board certified sleep specialist that has championed the dental sleep medicine collaboration to treat OSA for over 20 years. He ran the sleep medicine group for nearly 2 decades as a hybrid practice offering home sleep testing, autoCPAP, and oral appliance therapy, with his dental sleep medicine partners treating over 15,000 patients with oral appliance therapy and combination therapy over those many years. He's an early adopter of eXciteOSA for his OSA patients with compelling patient testimonials about the ease of use of the therapy. And so with that, I'm going to pass it on over to him to talk more about it. So thank you, Dr. Zelk.
Great, thanks, Jay, and thanks to Signifier for inviting me to talk about your innovative therapy. And thank you for all the clinicians who are joining us here tonight. Really appreciate your time, and I know how valuable it is for you. Hopefully we'll bring some really great insights on this evolving interdisciplinary world of sleep disorders and the multidisciplinary groups that need to be developed to manage this to the best possible measures there. So let's move on with the presentation. So the agenda, we'll do a quick evaluation of epidemiology. There's some really interesting, impactful mandates by the American Dental Association regarding sleep disordered breathing, and the evolution since the COVID-19 epidemic has changed the way we do medicine, and access to sleep partnership and telemedicine partnerships have been facilitated. So this is going to impact this whole arena. Then finally, I want to talk about the specific new therapy that we're here all to learn about, which is the novel treatment of eXciteOSA. You'll see some prevalence data here. Some of this looks pretty aged because a lot of the articles still today are quoting very small numbers like 4% of men and 2% of women having sleep apnea with pathologic sleepiness. And we know now that actually only a small fraction of patients are presenting with pathologic sleepiness at the initiation of their sleep apnea journey. Turns out that nearly 25–30% of women in modern day humans, especially the United States, and close to 40% of men are now dealing with obstructive sleep apnea and snoring. And almost 60% of the updated population reports nightly snoring issues there, as well as symptoms that could be attributed to sleep apnea. That being said, 80 to 90% of patients with obstructive sleep apnea are still undiagnosed. So how do we tackle that? I think some of the credentialing bodies are trying to actively improve that capture of this significant issue. And as we know, obstructive sleep apnea is essentially a sleep suffocating process where the throat gets pulled with negative pressure closed, and the patient cannot breathe for many, many seconds, causing oxygen drops and lots of mitigating issues in the body. The group of people watching tonight are going to be coming from established board-certified dental sleep medicine providers to general dental clinics who are interested in learning more about how they integrate screening and continuing education. And this is going to be a milieu for both questions from both groups of folks here. So the contributor to 90% undiagnosis, I believe, is partly the treatment is worse than the cure. If you do many of the surveys out there, if you ask a patient about the treatment of snoring and sleep apnea, they immediately think about obstructive sleep apnea being treated by CPAP alone. And it turns out if we can start to introduce less invasive, more patient-friendly treatment opportunities, we can actually start to get patients thinking about treating this earlier in its progression. And currently, with current surveys like the Stop Bang, the Berlin questionnaire, and using Epworth sleepiness scales, we're actually waiting 10 to 15 years on average until symptoms are consistent enough to meet the stop bang questionnaire. So we want to start looking at this earlier on, and that way we can really start to capture this 80 to 90% undiagnosed population. And partly by doing that, we need to understand who we're dealing with. It turns out that 60% of all obstructive sleep apnea patients are in the mild category. So this is our largest group of people that we really need to start tackling and as a team start evaluating and assessing. As we know, the higher the apnea-hypopnea index is, or the throat closure index per hour, the more severe the deterioration of the breathing patterns are during sleep, and the more disrupted sleep patterns are. So there's a linear relationship with the cardiovascular aspects, but we've also noticed that in the milder categories, we can start having perturbations and issues with sleep and fatigue and social issues such as snoring, even in the milder categories. So we need to give that more weight. The American Academy of Dental Sleep Medicine has done incredible work to catapult the information about trying to become more of an interdisciplinary team. And as you can see here, its initiation was basically in 1991. Despite all that work, in 2002, there was nearly 300 members. And 2 decades later, we have a fantastic increase in membership. Over 3,000 providers are in that group, but that's out of 200,000 approximately dentists in the country. So we really need to do more to get this introduced into the general dental practice. And why do I say that? Well, I say that because the American Dental Association a few years ago put out a policy statement for the role of dentistry in treatment of sleep-related breathing disorders. And that's important because there's specific bullet points that they're putting in there that are going to define whether you're meeting this new mandate. The first and foremost is that you need to start increasingly adding a comprehensive medical evaluation for potential SRBD to your dental intakes. To do that, you need to have continuing education. So it says to continually update your dental sleep medicine knowledge and training. And then, of course, at that point, it was really more about oral appliance therapy and being an expert in this region. Once the medical device of the oral appliance has been prescribed and a letter of medical necessity has been forwarded, that needs to be fitted by the trained dental sleep medicine provider. That was only one of many potential treatment options that you will be able to provide as a durable medical equipment distributor, which is what you are doing as you're fitting and adjusting dental appliances. That was appropriate for mild to moderate sleep apnea, and now the guidelines have been up to date so that if you're in the severe category, you're also appropriate for oral appliance therapy if, in fact, you refuse. If you prefer an oral appliance to CPAP, you're allowed to choose that per the guidelines. And that turns out, based on a number of research articles over the years, where it showed that up to potentially 70% of patients can have a 50% reduction in their apnea-hypopnea index in the severe category. That's fantastic for 70% of people. Now, that does mean that 30% will not have an adequate treatment response. And so we're constantly looking for ways of combining our treatment efforts to keep the airway open. So the ADA policy is really encouraging all dentists across the country integrate this actively so whole body dental care is integrated, because we know that if you're having sleep apnea with dry mouth and snoring, you're more likely to have bruxism, you're more likely to have periodontal disease, and of course, a number of other issues that affect blood flow to the oral cavities. So we've heard this a lot. CPAP is the gold standard. Yes, we can keep the airway physiologically open the best with all parts of the airway, upper airway passages with continuous positive airway pressure. The problem is even after 40 years almost of treatment with this therapy, in the best case scenarios, 3 years later, 50% of patients will be meeting the minimum criteria for compliance. So it turns out that long-term effectiveness is what we're really measuring versus physiologic efficacy. So that's why we're here talking today, is trying to give you more and more options than just CPAP. And let's face it, CPAP is an investment of your time and energy, and you have to understand the aspects that go into it psychologically when you're dealing with equipment and mask and the apparatus. So for an ADA mandated dental office to provide this new compelling mandate, we need to have easier access to medical providers who see things in a balanced paradigm. And telemedicine, luckily, as of 2015 by the AASM, really encouraged more partnership with telemedicine groups where we can offer sleep diagnostics via home sleep testing, interpretation with a multitude of treatment options, and then an LMN and RX to follow that up, that we can then provide easier access to treatment alternatives as most patients would prefer. And remember, the milder the case, the more likely they're going to want to do less invasive interventions. And that's when we want to start treating things as preventatively before years and years of changes in the cardiovascular health of the patient and mental status and fatigue-related issues. So also with COVID, telemedicine has become more refined, and we have a number of national entities that are providing telemedicine services for sleep. And much of that is being provided for partners in chiropractic and dental offices. Just to show you how we can start to integrate this into your general dental practice, you want to start using the easiest and most effective and simplest tools to get a high pretest probability for sleep-related breathing disorders. The first one, obviously, would be to ask the patient if they are snoring regularly and it's bothering their bed partner. Remember, 60% of modern adults have some level of snoring, so you're likely going to catch a number of folks who need your help. Secondly, if we look at the physical examination in the dental office, you'll be able to capture the early development of obstructive sleep apnea prior to the point where it's developing symptoms like we would do with a survey with the stop bang. So if you're looking at bruxism-related findings, if the patient's already on a bruxing guard, or if they have wear facets in the teeth or cracked crowns, that's a patient who's likely got sleep apnea. That's a 50% relationship there. If they have scalloping on the tongue, that's also turned out to be a very high predictive possibility of obstructive sleep apnea. So simply looking at scalloping on the tongue. And thirdly, a recent study showed that if there was an elevated Mallampati score, so if the Mallampati showed a 3 or a 4, where it's hard to visualize the back of the throat because of the soft tissue, that was also a high enough predictive value to actually screen a patient. So just make life easier on yourself and find the easy physical findings as you're looking in the patient's airway past the teeth. You can start to integrate this in your dental hygiene programs as well as your dental practices. In dentistry, there's been a lot of advancements where dentists are looking at the upper respiratory tract, not just for sleep apnea, but for improved nasal function, because they understand that that can affect periodontal status and oral health. And it turns out that if you are nasal breathing, you are doing an incredible job of re-encouraging the brain to breathe normally. It's going to have normal nasal air volumes, and it can also generate a significant amount of nitric oxide. And nitric oxide is fast becoming the darling for overall general health. The more nitric oxide you have, the better the airway muscles are going to respond to breathing volumes, as well as the other aspects of the what we call loop gain, or the breathing drives to breathe, the chemoreceptors as well as the baroreceptors. And if you're nasal breathing, then you can generate massive amounts of nitric oxide in the nasal sinuses, which could really improve and reduce the risk of upper respiratory infection, because we know that 80% of viral infections start in the nose. And nitric oxide is actually an oxidant. It actually kills off naturally foreign invaders. And that's why we want such a high concentration in the nasal area. Now, that being said, if you look at surveys, 39 to 45% of the modern day Americans are suffering from seasonal allergies. And so they're prone to having nasal congestion and having periods of time where they rely on mouth breathing, which can be addressed with proactive management and assessment. You can also see below the nasal passages in this image that the arch form, the maxillary arch, is deficient. There's a narrowing where there's tipping of the teeth. And that's also a structural change that's happened over the last 100 years, where we're noticing that weaker muscles for swallowing and mastication, with a number of reasons, are actually affecting overall airway health and arch development. Many of you are likely familiar with the cone beam CAT scan in the modern dental office, doing all the advanced dentistry out there with implant dentistry and whatnot. Turns out that cone beam CAT scan is an incredibly powerful way to communicate this message to your dental patients. When you're evaluating the airway, you can do a volumetric assessment and show them with a heat map where things are narrowing on the patient while they're awake in upright position. But it's very impactful for a patient to visualize that, even though we know there's more to the equation here, like muscle relaxation and sleep and whatnot. By seeing this, they can get a visual representation of what we're trying to manage. So this is another tool where we can look at active nasal volumes, as well as turbinate inflammation, if there's any septal deviation, as well as arch development in tongue posture and posterior airway space volumetrically. So really powerful tools that I've been excited and been really fortunate to have been exposed to early on by being a partner with dental offices early on in my career. We also want to take into account the elephant in the room, which is the increasing body mass index of the average modern human. It turns out that in the United States, surveys can lead anywhere between 25, 28 to 45% of the population is in the obese category above a body mass index of 30. And you can see here in this slide, the picture on the left and the right are the same person, but with a significant amount of weight loss. So this person had about a 40-pound weight change from the baseline to the left on severe apnea to mild. The yellow shows the adiposity or the marbling effect of the fat cells that were already there at birth. But as we gain weight, all of our fat tissues grow, and you can see the significant change in not just the submental fat, but even the intramuscular fat in the tongue. And as that's lost, it will shrink and the tongue gets smaller. But the reason why I show you this is the larger the tongue gets, the stronger the tongue gets, but it gets weaker at the same time, meaning the endurance of the tongue is lost. So many patients can be pushed into a sleep apnea scenario with that weight change. And don't forget, research shows that a 10% increase in body weight can actually increase your apnea index, your AHI, by 26%. And a 10% loss can reduce it by 21%, because part of that fat adiposity is left there during the yo-yo phenomenon when you're going up and down in weight gain and weight loss. So once it's distributed to the tongue, it's typically taken out later in the weight loss process. So that's why many patients will notice that it doesn't totally resolve with weight loss. But this gives you a really great imaging of how the airway can dramatically change in volume with that tongue size change in the same person. Interesting, look at the loss of curvature on the left when the patient was in very severe survival mode and how they developed more of a curvature in the cervical spine later on, and actually a much more relaxed posture of the neck. We're at a really incredible nexus where because the common public has had access to some really incredible top sellers lately, Breathe by James Nestor, Sandra Kahn, an orthodontist in California, showed arch development problems in Jaws, the story of a hidden epidemic, and then with Patrick McEwen talking about buteyko breathing and the importance of appropriate nasal breathing versus mouth breathing and how it can affect your overall health. More and more patients are aware of these issues, and they're more tied in and really bought in to that dentist who's actively looking at the whole airway and specifically improving nasal function. I am a previous mouth breather as a child. It took me many years to decide that that's actually something I need to correct. And since I have, it's been an incredible journey. Obviously, in a normal size person, by body mass index, many of us are developing sleep apnea due to these facial development changes. So just be aware that this is an important sort of catalyst right now for you to discuss this with your patients. I hear this very commonly in my telemedicine consults with my dental offices, that the patient's wondering, why is my dentist talking about all these health issues? And this is really what's great about this, is you're coming full circle as their overall other primary care provider looking at their breathing and health and how it connects to their dental health as well. So that brings us to the role of myofunctional therapy. Many dentists are familiar with this, and this is basically a paradigm where we're focusing on normal head posture, tongue posture, and in order to have good tongue posture where the tongue's in the roof of the mouth, you need to have an appropriate nasal function. And so encouraging appropriate nasal breathing, as well as tongue mobility and tongue strengthening exercises. And there's good data out there that shows that a myofunctional therapy intervention can actually reduce sleep apnea and snoring by 50%. And this has been noticed in polysomnographic assessments, not just subjective surveys. Patrick McEwen has repopularized the BRE, or breathing reeducation. That's an important part of MFT. And that was popularized by Dr. Buteyko, the pulmonologist who started Buteyko breathing exercises. So the standard myofunctional therapy recommendations would be to try to basically support the external nose through nasal dilators first, because that's becoming more common. Then trying to encourage the mouth to stay closed, and that's very typically going to be mouth tape. I encourage folks, if you have snoring, to screen and rule out sleep apnea prior to any patient trying mouth tape, because that could worsen sleep apnea potentially. And of course, improving sinus care with a nasal hygiene program to hydrate the tissues of the nose. Remember, the nose, it's dry, it's going to be swollen, just like the mouth. If the mouth is dry, it's swollen and irritated. The nose is the same way. So integrating some hygiene regimens like clear nasal spraying can be very, very helpful. And the reason why this is important is 50% of the negative pressure generated to the upper airways can be attributed to poor nasal function. So if you already have smaller dental arches, smaller nasal vaults, and smaller orbits to support the soft tissue of the skin, so the skin's more collapsible of the external nasal nostrils and the nasal valve, then we need to start thinking about nasal function first, and then the airway tissues after that. So don't forget, always think about nose function in your patients. And the reason why I bring this up, if you're a lifelong mouth breather, you're also a lifelong weak tongue breather, because the tongue as a habit starts to stay in the mandible and doesn't stay up in the roof of the mouth and develops a weaker posture. And that's why we're going to start talking more about ways to improve the endurance of the tongue muscle based on this long-standing history of poor nasal function. So we've established increased rates of sleep apnea, increased rates of arch restriction, which is going to develop poor nasal function, as well as atopic disorders or allergies. And that's contributing to the epidemic of weak tongues and dilator muscles of breathing and eating. And this graphical here shows us the phenotypes that we're addressing. And remember, CPAP can blow past all these issues, but it's a Band-Aid. We'd like to get to the root cause here if we can, and make our patients healthier as earlier on in their process. And you'll see here that the site of upper airway collapse is a contributor, the smallness of the airway caliber, the oversensitivity of the ventilatory drive. So basically, if you're a mouth breather, you respond too quickly and too aggressively to perturbations in your carbon dioxide levels there. And poor pharyngeal muscle response. So again, if the tongue is not, or the other dilator muscles have a poor endurance, they can't respond and keep the airway dilated in response to airway restriction. And over time, that will also be exacerbated by low arousal thresholds. So then your brain's supposed to actually respond by tightening and toning the tissues in the throat as you're having the airway collapse. But if you're not having that, it turns into a negative feedback loop. This was another graphical that demonstrates something very similar when they were testing patients for postoperative complications. And it turns out that not only are we having smaller arches, which is an impaired upper airway anatomy and nasal vault anatomy, but weaker muscles because we're more mouth breathers. And then finally, we are having a negative feedback loop because we're mouth breathers. We don't actually breathe in appropriate required volumes in response to carbon dioxide changes. So it's a vicious cycle that we could easily tackle with a couple of extra little adjuvants. That brings us to our Excite portion of this lecture. So eXciteOSA is a daytime therapy. And what that means is anytime someone has to wear a therapy while they're sleeping, there is a problem with adherence in some patient populations. That's why we're not talking about CPAP to everybody, because 50% of CPAP users won't be compliant or adherent to the therapy. Dental appliances are really much, much better tolerated. Most studies show anywhere between 75 and 85% of patients will still be wearing it throughout the night at 2 to 3 years and sometimes longer. The problem is you still have patients who may have jaw pain related to it. Maybe they're not a great responder or a full responder to the therapy, or they outright cannot tolerate it due to gag reflex or other periodontal status issues. And that can be a total of probably 25 to 35% of that population. So now what do you do for them? Well, if CPAP's not going to work, they can't wear a body positioning element, and the dental appliance is not necessarily an option for them. Now you have an option for a daytime therapy. Of course, there are implanted devices like the hypoglossal nerve stimulator, but typically there's a significant amount of other treatments that need to be trialed and failed prior to being a candidate for hypoglossal nerve stimulation. And it's still quite invasive. So I typically leave that for my recalcitrant patients to most other therapies. So a less involved or worrisome or a much safer thing to look at right off the bat for my mild patients would be the eXciteOSA. And the reason being is eXciteOSA is a daytime treatment that only requires about 20 minutes of the patient's day initially. And then over time, it's only a few times a week. And what is eXciteOSA? Well, basically, it's an intraoral daytime appliance that you apply to the tongue. And then it uses neuromuscular electrical stimulation, NMES. I'll be saying that throughout the rest of this talk here. But NMES is essentially a way to improve the motor nerves of the body and improves the responsiveness to the muscles in response to the connections with the nerve endings. So many people have heard of TENS units. Well, that's more for sensory pathways to reduce pain. NMES is regarding motor function or neuromuscular function. And this has been used in many different categories in physical therapy applications and whatnot. So now we have one more option for our snoring patients who are screened negative for obstructive sleep apnea, or for our mild patients up to 15 AHI. Why are we looking at eXciteOSA? Well, it turns out, and any patient can see this on the diagram of the upper airways, the genioglossus muscle is by far the largest soft tissue in the oral cavity. And that's specifically where this device is working. And we've already established that many of us are developing weaker and weaker muscles due to a number of lifestyle and phenotypical responses to our environment. So now we need to come back and try to address that by getting back to increasing the endurance and the tone of the largest muscle of our upper airways. And essentially what we're doing is we're trying to turn, through a conditioning process, these muscles into these stronger but weaker as far as endurance muscles to more endurance tolerant muscles. You'll see here that the average sleep apnea patient actually shows above average strength of the tongue. The problem is that it also shows a below average endurance, and that turns out to be the most important aspect for airway, because think about it, if you're breathing anywhere between 6,000 and 7,000 breaths in a night, you need to have that tongue and those dilated muscles responding to each and every one of those breaths like a marathon runner. You don't want Arnold Schwarzenegger in your tongue. You want more of a endurance runner in your airway. And if you look at these images here, you'll see that the apneas and hypopneas are caused by a collapse from negative pressure. We're sucking back those tissues via the Starling response there. And you'll notice here that if you have less endurance, you're more likely to collapse those tissues. And what led the eXcite group to study this intervention was they found that in other applications, the improved endurance improved performance of other applications throughout the body. So they went ahead and came up with a specific protocol, a series of different pulses, ranging from between 30 and 20 hertz. And it turns out that by utilizing this, you can actually convert fast to slow twitch muscle fibers that are going to improve their endurance capabilities. And that's what we're hoping to do, is get more endurance of the genioglossus muscle so it can last the whole race, the whole night. Let's go through a video that talks a little bit about this more in depth from eXciteOSA.
With the aim of improving endurance of the upper airway dilatory muscles, eXciteOSA provides a novel daytime therapy for patients with mild OSA and primary snoring. The compact device applies low-frequency neuromuscular electrical stimulation, NMES, via 4 electrodes that rest directly on the tongue, stimulating the upper airway muscles. Simple and comfortable to use, the daytime therapy requires only 20 minutes of NMES each day to increase responsiveness and prevent excessive relaxation of the tongue muscles during sleep. According to clinical research in skeletal muscle stimulation, NMES has been shown to result in a change in myofibrillar protein expression to induce a phenotype shift from fatigue-prone to fatigue-resistant fibers with a strengthening of the cytoskeleton. In summary, eXciteOSA's innovative, clinically proven daytime therapy trains the tongue and upper airway muscles to be more resilient against mild OSA and snoring.
Move on from there. There we go. So just to rehash that, they did a much better job of presenting that with a much neater accent. But basically what we're looking at is a daytime treatment. And I tell my patients this, it's a daytime treatment, 20 minutes a day. It's not the whole night, right? And that tends to be pretty much an area that they like to hear, that they don't have to wear it the whole night, essentially. It's 20 minutes a day for a 1 time a day for 6 weeks. And after that, to maintain that level of endurance in the dilator muscles, we typically would suggest twice a week maintenance treatments at 20 minutes once a day. So you'll see here, they've really developed a partner or a companion application that's very descriptive of the patient. It's good instruction. It talks about sleep issues in general, lots of information for the patient to help you guide them through their journey. And what it does is it walks them through each aspect, connecting it to Bluetooth, connecting the device together, placing it into the mouth. It will even give them little nudges and reminders if they've missed a day. And in the end, we have pretty good visibility as far as usage. That's what's been really powerful for me in my practice, is that visibility of their actual adherence to my treatment recommendations. And as it mentioned before, it simply goes through a series of cycles. So it goes through 3 hertz first. It'll go 10 hertz cycle of pulses, 20 hertz, and then back to 3 hertz. Patients will very easily and quickly acclimate to this treatment. It's not challenging whatsoever, not painful. We'll talk about some of the reported side effects and what the patient experience is like here in a moment. So essentially what you're going to do for every patient is they start off at a very low intensity, almost imperceptible on the application. And that's how you're going to adjust the intensity, is in the app on the unit, as long as the Bluetooth is set. Then what's going to happen is over time, you will start them in the lower therapy level, give them confidence, but you want to encourage them as soon as comfortably possible to move into the higher therapy levels. Typically a minimum of 10 on the intensity gives you the most efficacy. I prefer getting patients as close to 15 as possible. Give them time, and everyone's going to adapt to it at their own pace. There is interpatient stimulation tolerance. So I rarely see anyone that can't tolerate 10 or greater over time. And as you ease them through the process and encourage them in the initial education, they'll mostly, I haven't seen anyone yet be able to at least get to 10. Most of my patients get to 15 after the first 2 weeks. This is a example, a screenshot of the dashboard that's the prescribing provider can actually assess the patient's adherence to therapy. We can see in the green that they're maintaining their daily usage. In the yellow, they may have missed a day or two. The red, they're missing more than a few days a week. And then we can give them little cues and nudges to encourage compliance, or at least see what's going on their end. At the end, they're going to go to 2 times a week. And so that's going to be a little bit different appearance on the actual dashboard, but we can easily visualize this. And this is what's so powerful about this part of the treatment response, is we can see that the patient's actually doing as we requested. There's a lot of really well-developed exercises for myofunctional therapy, but long-term adherence to this is very challenging, almost as challenging as CPAP adherence. So this gives us a very simple way to at least tackle the tongue strengthening, the endurance improvement process of dilator muscles along with the other aspects of myofunctional therapy. So you'll see here, there's been many research trials being performed since 2018. And the first place this started was in Europe. So there's still a lot of things that we've learned off of their early access to this sort of therapy, which has been pretty exciting. But essentially, you show here that there was at least a 39% to 41% reduction in snoring on this initial clinical trial. And you noticed even in the very loud patients, you had 54% or even 52% reductions from the very unacceptably loud social snoring down to a milder, less disruptive snoring pattern there. You'll see here in regards to obstructive sleep apnea, they found that in these trials, in 65 patients sample size, that 78% of patients were responders. And you'll notice here that basically they had that apnea-hypopnea score treated down below 5 over the whole night. And why is that important? Well, compliance. So with the CPAP, if a patient's able to wear it for 4 hours, you're missing 3 or 4 hours of treatment. So the fact that a daytime treatment can impact all night apnea-hypopnea index is pretty game-changing here. And what you'll see here at the bottom is that 78% of patients were considered responders to therapy. Many of us familiar with the Epworth Sleepiness Scale look at a pathologic Epworth Sleepiness Scale above 10. But it turns out that even patients that are not in the pathologic level can discern an improvement in their daytime function and alertness, even in the relatively accepted ranges. And it turns out that here, this is also the case, where patients were checked with the Epworth Sleepiness Scale in the mild categories. And you can see here that there was a 3.4 point reduction in the Epworth Sleepiness Scale. Well, if the patient's totally alert and unimpacted, you'd see no changes. So this also encourages us to start actively looking at our mild patients and not just trying to brush them off as a potential, elective issue here. This can actually make a big difference in someone's quality of life and function. And then in supporting research here, you can see that those were replicated. Here is an example of the adverse events related to eXciteOSA. You'll see here that more people were reported earlier in week 1, and those same people will actually report very little of those same side effects as they approach week 6. It's important to note that there's been no serious adverse events reported with eXciteOSA or NMES, and 85% of study participants did not experience any related adverse events. So these are the very small 1%, 2%, 3%, about 10% of patients might notice some sort of pooling of saliva initially, which is going to be expected because you're activating these muscles there. You're putting something in the mouth, which is going to encourage salivation. So obviously that takes some preparation for your patients. And you'll also hear some patients mention a little bit of tongue tingling while they're actually actively going through therapy, not after therapy. Some will mention some tooth sensitivity, maybe a metallic taste. Some, if they put the unit in too far, it'll be a little bit of a gag producer. It is a one-size-fits-all device there, so you want them to diligently place that at their own comfort. And if it's working well, you'll typically note some tension in the submental area and in the jaw because you're actually toning and strengthening and improving the endurance of these dilator muscles. So I always tell patients it's a good sign if you're noticing jaw tightness. And just to confirm the point here or belabor the point here, endurance is what we're looking for. We don't want to make the tongue any bigger. We want to make it more toned, essentially. So they found that with the intraoral pressure transducer here, that they did not change the strength of the tongue. They merely changed the endurance and the tonicity of the tongue. And this is really exciting because we're all focusing on adherence. Now we have, after a couple of years of data in real market assessment, 80% or greater adherence to the therapy in over 3,561 patients. So that's pretty impressive as far as patient tolerability. This is what we're trying to do with giving you more and more tools as a dental sleep medicine partner in the journey of these patients is giving you things that are easier access and more patient-friendly interventions so we can start tackling this early in the disease progression. So regarding clinical experience with eXciteOSA, I was lucky enough to be approached by Signifier to help them address any questions that the FDA had, since I have some experience with FDA process there with medical devices, and everything went through with flying colors. It was really quickly adapted to our FDA in the US. And it turns out that this has been very, very impactful for my practice. What we're doing typically as a sleep service is we largely focus on, in a national sense, all 50 states, dental offices and chiropractic offices and primary care offices where we can give them easy access to sleep services. Because right now, awareness is increasing for sleep apnea. So many sleep centers are actually getting booked out 1 to 2 months out or longer. And so with telemedicine services, many times you can get in to see one of our specialists or other provider services within days, if not a week or so. So that is something that I want to disclose with you. I'm the medical director for Sleep Balance Academy, which is a telemedicine service, sleep services for dentists in all 50 states, and as well as a lecturer for the Airway Institute, which focuses on advanced dental sleep medicine training and aligners for expansion or dimensional development of the airway. So how do we use eXciteOSA in our practice? Well, typically, if you're a dentist client of ours, you're going to access our telemedicine services, obtain a consultation after screening in the office. And then, of course, if the screening tests high for positive risk for sleep apnea, a home sleep test would typically be prescribed. And then once that test has been completed, either there's primary snoring that needs to be treated, mild, moderate, or severe sleep apnea. And a multitude of treatment options can then be recommended via interpretation. And then as well, the RxLMN can also include a list of different treatment options that would be something to be discussed with your patient in your dental office. If you're going to start the eXciteOSA, you're going to want to use their instructional video, show them some samples to demonstrate what it looks like and touch and feel. Of course, eXcite has a portal that we can check and monitor that on a weekly basis as the prescribing provider, the partner. And then over the long term, the ePros is the actual dashboard that we showed you. Will give us an idea of what their usage data looks like and adherence to therapy and intensity. But also you're going to want to include some sort of snoring assessment. So Snore Lab, a Snore Doctor, Sleep Cycle. So you can watch the snoring intensity reduce. And at 6 weeks, typically we will do a sleep evaluation of some sort, whether it's a sleep study or just an assessment of how their reports are from home for snoring. And we also tell these patients upfront, expect some initial hypersalivation during usage. You'll learn to kind of, pull the therapy out and swallow while you're using it and just keep going without stopping. There can be some tongue-based soreness initially because you're literally working out and improving the endurance of these muscles. So that's actually a positive finding that they're applying enough endurance improvements in their tongue base. But it's well tolerated, and I've had no patients unable to tolerate the therapy. So case studies wise, so I want to give you a couple of patients that I would give you just as an FDA cleared recommendation. If you want to talk about anything that's off label, we can talk about that in the Q&As there at the end. But essentially, this is a male, 48, athletic, relatively normal BMI because he's muscular. He's above the 25 at 28. But because he's muscular, he has a 17-inch neck, tongue scalloping, and some nasal restriction. So we screened him, has the Epworth Sleepiness Scale of 10, tonsils removed remotely. His apnea-hypopnea index was 10 with a nadir of 90. So it doesn't look severe. It's definitely a mild case. And he was intolerant to oral appliance therapy and declined CPAP. We started with nasal hygiene first, nasal dilator, nasal hygiene regimen there, and then applied the eXciteOSA. And basically the patient was able to move up to an intensity of 15. At 16 weeks, we were to reassess him. We found that sleep cycle had him treated to no snoring. ESS was 6, and his follow-up sleep test study was 4 with an improved nadir of 92. Here's another very common case study where I think we haven't been able to really address until recently. Young females are also prone to snoring, especially with smaller airways developing there. So this is a 22-year-old student with a normal body mass index, which I found some tongue scalloping. We screened her for obstructive sleep apnea, which was not present. Her Epworth was normal. She does have a family history of sleep apnea. Her father wears an oral appliance, and she had normal sized tonsils, if much of anything. After the screening, because she wanted to do the screening just to be sure, because she has a family history, it turned out to be negative. So the patient then went on eXciteOSA, made it to the 15 after 6 weeks. Roommate is happy. No snoring reports are concerning. So these are two really interesting case studies that we're seeing in a standard case usage there. Now, of course, having many, many patients that are on dental appliance therapy who are much improved, but not fully treated for their snoring or not down to 5 AHI, we've been doing a lot of combination therapies off label where we add the dental appliance along with the adjunctive treatment of the eXciteOSA to improve their overall treatment response. So just to kind of cover up on the last slide here regarding the FDA authorized usage there, this is a neuromuscular tongue muscle stimulator. And it's been shown to reduce snoring and treat mild obstructive sleep apnea. This is a prescription device. So even if it's snoring, we want to obtain a prescription to have on file so that if we are dispensing DME as a dental sleep medicine partner, that can be basically that need is met there. And of course, that's the indication, like I mentioned, snoring and mild obstructive sleep apnea in people above 18 years of age. Right now, the contraindications are, we haven't tested anyone that's pregnant, so there's a contraindication of pregnancy. It's encouraged, not contraindicated in patients who are wearing implanted electrodes or pacemakers. I'm sure that includes Inspire because that is a type of pacemaker. If they wear a tongue ring, if there's any active mouth ulcers, so let them make sure they have those aphthous ulcers or whatever is going on actively or acutely treated before you start this therapy. And of course, it's indicated for anything below 15 AHI. There are some resources being developed by Signifier where they're developing billing codes for the durable medical equipment, and they also have support here. So as an office who's interested in offering this for your patients, feel free to reach out to eXciteOSA.com and they can get you brochures, some sample units there to show patients. I always find that as a clinician, if I can experience myself, I'm a much better teacher for my patients when in regards to the therapies that I provide for them. So I encourage you to practice on yourself as well to see how this is tolerated in your own N of 1. They also provide Zoom in services. So if you plan on providing this in your office along with your other options for snoring, then they can give you resources to train you and your staff remotely. And then finally, there's actually some resources on the eXciteOSA.com support-hub reimbursement where they're giving you more and more assets where you can actually submit those for potential attempts at getting reimbursement for the care. Currently, it's a case-by-case scenario. It's not handled the same way that CPAP or dental appliance therapy would be treated. And I thank you so much for your time and your attention, and I look forward to answering any questions that we may have. Probably more toward the real-world clinical use cases would be the best. Off to you, Jay. What do we got?
Great. Thank you, Dr. Zelk. That was a lot of really great information. So thank you.
Very welcome.
We do have some questions that have come through, and everyone that is still on, feel free to ask questions in the Q&A. And any that we don't get to, we can also respond separately in an email. But first question we have is, so they understand that the tongue is part of the obstruction, but how will this keep the tongue out of the oral pharynx during sleep, especially during supine?
So part of the issue, remember the phenotype slide I showed you earlier, there's a number of contributors to this. And so some of us are thinking about the jaw or the mandible relaxing and falling backward. Well, as the tongue improves its endurance, it naturally wants to stay into the roof of the mouth. And during those intraluminal negative pressure events, as you're sucking inward, the muscles actually respond to the arousal threshold. So over each event, if your tongue is more and more toned, your brain responds to it earlier in the area restriction. So it can actually stop it before it starts, essentially. So over time, with good nasal function, appropriate tongue endurance, and tongue posture, even on the back, we're noticing in mild obstructive sleep apnea and snoring patients that the mouth will stay closed. And that's partly what's been noted in myofunctional research, as well as mouth taping research and nasal restriction being addressed in those research articles. That's actually improving the mouth staying closed in general. Now, some of us have a relatively small dental arch, and we are trained mouth breathers. And so those patients may in fact need some sort of combination therapy, say maybe a stable mandibular advancement device.
Great, perfect, thank you. Another question, would this be good to use with patients using Invisalign or with braces?
As you can see, I'm wearing aligners myself, and part of my group, I'm actually correcting some long-term bite changes related to oral appliance therapy for many, many years of usage, as well as developing my arch form because I had lingualized tipped teeth and some crowded dentition. And we're actually using aligners to actually expand and give me more volume in the airway so my tongue more naturally sits in the roof of my mouth. So this is absolutely one of my go-tos when it comes to someone who's done well on dental appliance therapy, but they want to do aligners now, and they're definitely not going to use CPAP. So that would be one of my go-tos if someone's choosing to do aligner therapy. And we should be looking at that in any of our patients who are looking to go through dental alignment therapy. We want to be looking at arch restriction. So that means there's probably some snoring. So at least screen them for the snoring. If it's the case and they're primary snoring or low risk, give them that eXciteOSA. They can actively go through that during the aligner therapy. Good question.
Great. And to that point, yeah, I think people just have questions about other dental work that patients may have. So I can just talk to that, and that the FDA did approve the removal of temporary or permanent metal implants, dental braces, and intraoral metal prosthesis restorations and appliances from the contraindication. So it's really opened it up, and so we can reach a wider audience, which is exciting.
That's great. That's really great. One thing I know folks are thinking about, even if they haven't asked it yet, but after treating patients with dental appliances for 2 decades, patients really, really like it compared to CPAP. They're going to stay adherent and compliant to it. But we know if you've been treating any patients long enough, you're going to be partially treating many of those patients, especially in the moderates and severes. So we have been following some of the same sort of patterns that even dentists in Europe have been doing for some time, where we add the eXciteOSA to improve the endurance of the tongue, to improve the overall oral appliance therapy. So that's something we're doing off-label as a combination, just like you would do with CPAP therapy. If a patient's not tolerating CPAP, the dental appliance doesn't fully treat them. We've been combining that for many, many years to lower the pressure, so the patient's going to tolerate CPAP more effectively, and reduce the advancement so there's less likelihood for jaw changes with the oral appliance. So by combining those two, that's become a sort of normal thought process for many people now. When I first introduced that to some of the early adopters many, many years ago, people were asking questions, why would you wear both? Well, these are the reasons why. This is another type of what we call combination therapy to get us going better over the long term. And here's one other thing that we may want to be aware of. With long-term dental appliance therapy, there are some studies that have shown some loss of effectiveness to mandibular advancement, where we've lost some of the effectiveness or efficacy. So we're believing that some of that is related to tongue tone loss or weakness, because we're relying on that jaw protrusion. So this would be an area to start investigating to improve tongue tone early on in endurance, so that even though jaw advancement is helpful, if you lose the muscle tone, you're going to lose some of your potential benefit over the long term. And we're looking at 10, 20, 30 years potentially for patients over the long term, that we don't want them to lose the benefits from their current therapy that they love so much. So just a point to think about.
Perfect, thank you. Another question is, are you using any of the PROMISE questionnaires? So the patient reported outcome questionnaires.
You know, my go-to is not adding a bunch of, you know, a lot of questionnaires are for research, right? So my big thing is to try to keep things simple. You know, I want to keep things simple, essentially. I will use, if it comes to nose, I will use the nose survey. I'll look at the physical collapsibility of the nose. But when it comes to some of these metric devices, I'm probably going to not be the one going through and checking off all the multitude of boxes here. I want to look at the patient in a global way, essentially. So I'm looking at physical findings, and then are they subjectively better? Do I see, am I addressing each airway of potential collapsibility? But I'm not actually going through the PROMIS questionnaire typically.
Okay, perfect. We still got a few more minutes. So another question, have you used cone beam CT to see if the airway opens or is larger after eXcite treatment?
You know, that's something where we've been collecting before and after data. And so what we're really seeing is we're seeing tongue posture. And because the tongue doesn't really change its size necessarily, it's just more toned essentially, and it won't fall back as easily. We're not seeing any obvious tissue changes as far as a measured volume, but we see a better ability to stay in the roof of the mouth. So if you've done a bunch of CBCTs, a lot of folks who have poor tongue posture, you'll see that void of airspace in the roof of the mouth and the tongue sitting downward. So we can see that specifically. But when we're looking at the effect of the therapy, the CBCT is just to give us more information to tell the patient, hey, this is a big part of your problem. Let's make sure we've strengthened it, toned it up, and then, of course, address the other aspects like arch development, if we've noticed enlarged turbinates, septal deviation, that type of thing. Or if at the hypopharynx area, if there was also another restriction as well there.
Okay, thank you. Another one question could be, so someone using this, do they bite on the mouthpiece to hold it in place, or how does it stay in place in the mouth?
That's a really great question. So let's do some practical stuff here, right? So the first thing is you do not want to be biting on this thing. So essentially what you're going to be doing is placing it so that those little leads are 2 of them are going to be touching the top of the tongue and 2 are underneath the tongue. And essentially you want to gently keep it in place with the lips. Okay, don't bite on it because you could actually start, kind of work, age it too quickly and it may actually fail on you. I haven't seen that yet, but it's potential. So just basically keep the lips firm on the device there. What you'll notice too is as it's going through the pulsing, you will get salivation. And as a user myself, I noticed that I've gotten good at it goes through the pulse and then it pauses for a few seconds. It goes through the pulses and pauses. So during that pause, I take it out, take a swallow, pop it back in. Didn't have to do anything on the app, didn't play with the app at all, didn't pause anything. Just naturally, we'll start to get in the habit of being able to get your swallow response out of the way. So don't bite on it, just keep it placed on the tongue. You'll feel it pulsing. And what's interesting is at first, the pulsing feels different. It's new, it's not painful. There's nothing noxious about it. But over time, as you start to get closer to those 15 intensities, if you don't get the 15, you're feeling like you're not getting all you can out of this thing. So most folks will want to end up doing that over time, is getting to that intensity there. But definitely don't chew on it, don't bite on it. And it's actually not really close enough to the teeth to really bite on typically, unless you have a smaller arch form, but you will have it, in between the incisors.
Great, thank you. Well, it looks like we're running to the end of the webinar. And I just want to say, I think this is really helpful information. I mean, myself going to the dentist, I've now started receiving that questionnaire about sleep apnea. So I know it's much more important to have different alternatives and options for those patients that may not be looking to CPAP, or they may be intolerant to CPAP or MAD, but it's also working in adjunct. And I know you talked about that as well. So I want to say thank you so much for having this great discussion. And thank you everyone for joining the webinar. And I'll leave it to you, Dr. Zelk, if you have any last comments.
Yeah, just one more point about dental indications. If you have a patient who's failed dental appliance therapy because they have a strong gag reflex, or maybe they've been wearing a bite splint, because a lot of patients who have apnea have a relationship with bruxism, but they don't want to invest or go through the whole process of going through an oral appliance. this would be a great opportunity to try to manage that with this daytime therapy. Because again, it's a daytime function thing. And what's really important too, what I've noted to patients is that the more toned that tongue is, the better healthy we swallow over time. And I'm 50 and I'm in another decade or so, I don't want to be choking on my food. So that's one of the other reasons why I do this actively is I want to be preventative, keep that airway healthy, as well as, open at nighttime. So just be thinking about that for your own health as well as clinicians. So
awesome. Thank you so much. And any questions that we didn't get to, we can answer separately after this via email. But yeah, thank you all for spending time with us tonight. And I hope everyone has a good evening.
Have a great night. Thanks for your time, everybody.